So now we're going to move on to our panel discussion, and we're going to bring in two folks from MSF, in addition to some of the speakers. Joining us will be Michel Quere, the Medical Support Officer for Community Health Approaches, Preventive and Curative Packages, and Teresa San Cristobal, the Director of Operations for Médecins Sans Frontières Spain. Michel, I'm going to bring you in first to this conversation and follow up on some things Jerome was saying. Most of the presentations that we heard from came from relatively stable contexts. What are some of the dilemmas that are faced in unstable contexts where we want to implement a community health approach? Are you with us, Michel? Okay, we may be having a little bit of connection difficulty. We'll come back to Michel later. How about Teresa? If you could maybe try to handle a similar question.
Yeah, I mean, for OCBA, we mainly work in conflict and very unstable settings or in response to emergencies. And I'm going to talk not about the medical part, but about the challenges that we have. I mean, if we put the example of Mali, community health workers that we are working with is young people with a lot of mobility that they are quite frequently target because of their position, because of their age, because of their mobility. So basically, I mean, for us, we have a lot of discussion on how to protect this group of people in violent environments, in places where there is a lot of persecution of young people. So we are analyzing things that they were mentioned before about what is our real relation and our duty of care of people who is working, regardless if we say half a day, 24 hours a day for us, and what is our contractual relation and our duty of care with them, how we expose less to the people in this kind of context to, for example, refilling drugs and moving to trainings and things like this, that they expose them a lot, and how also we select the people to be sure that they are well accepted by the community. But for us, as you know, is the continuum of care. No, is how we create the relation from the community to the health center to the referral system to the higher referral system. But for most of our decentralized model of care programs, they are in conflict setting or in emergency settings. It's true that in emergency we still face many challenges to be fast on developing it, depending on the settings. But in general, I mean, we are having a lot of debates on the security of the staff. We have seen in Burkina, we have seen in Mali, we have seen in many places, to the security of this group of people and to the relation that we have with this group of people, that it is quite fragile, if you want, no? Because we say they are community health workers, they are not MSF workers, but at the end they are working for us. So we are now having a lot of debates, and now we are creating a guide of what we want to be our relation. I don't know if I answered your question.
Yes, I think that was a very wonderful answer. I'm wondering if Michel, are you able to join us? I think there may still be some internet issues with Michel. We'll hope to bring him back as soon as. We're all members of institutions, and one of the questions I have is how institutions actually receive some of these new ideas. So maybe Abdias, I would like to bring you into this discussion. to see if you can tell us how Action Against Hunger, ACF, sort of first received these ideas of community healthcare worker managed severe acute malnutrition treatment, and what allowed the institution to back the idea and start implementing it, and now you're moving to scale.
Merci, Kevin, pour
Yes, thank you so much, Kevin, for the question. We at ACF, Action Against Hunger, we think that in order to reach out to more malnourished children in the community, we should manage malnutrition as close as possible to the community and put the system at the heart of our action, involving everyone, the community first, of course. And in order to select the ASCs, which is community health workers, you've got to select them well with the support of the whole community so they're well accepted. We are now just about to scale up this PCIME approach in Mauritania. We're scaling up in a whole region in Mauritania. So we're really committed, and we do have this expertise at ACF. Our missions in Mali, Niger, Senegal, we support health work there as well as in Mauritania. And we're opening up to this new thinking for other countries to see how we can scale up this new idea involving CHW. With the COVID, mobility is hindered, but we can supervise remotely and motivate instantly. And also at the level of our headquarters, we've got all the mechanisms to keep supporting this process. We're strongly motivated to decentralize healthcare at the community level. Over to you. Thank you.
Thank you very much, Abdia. So I'm going to come back to you, Jerome, and sort of get into this discussion about remuneration. You say that it is costly, even though it is cost effective. There is a cost there. Who do you think should finance the remuneration for community health worker-led services? Are we talking about governments? Are we talking about international donors? Some combination? Over to you.
Thanks. I think this is a question for the remuneration of the primary healthcare workforce as a whole. How do we make sure that the health workforce is paid at a decent with a decent salary, and I think it's a wider discussion, and it's actually also a discussion that is not specific to countries with a humanitarian crisis. We can see with the COVID-19 pandemic that the question of the sustainability, the financing, and the working condition of the workforce is key everywhere. On specific, I'm not trying to avoid the question, specific to community health workers. I think there is a need to estimate what is the remuneration, because it's not necessarily standard, as Teresa was mentioning. Sometimes we use community health worker for a small portion of their time, or smaller a part-time because they also have additional activities that they continue to have within their communities, and actually sometimes they are selected because they are already part of and have community activities. So it needs to be proportionate, and it needs to be estimated based also on the local economy. We have experience in the DRC in the Ebola crisis and in other crises that when you provide remuneration that are too high, it can completely destructure communities, and so it's also something we need to be very cautious about, not to challenge local economy and ecosystem, but at the same time, we need to make sure that we are not exploiting people and that we provide a decent salary. So there is not a magic number about how much should be paid. It's based on a local analysis, estimates, and negotiation. Who should pay for it? I think when we're talking about institutionalizing community health workers as part of the health system, it has to be part of who is paying the health system. And of course, international donors support some of the health system cost. International organization, non-governmental organization as well, sometimes when there is an acute event with providing additional support. That's all part of what should the system that can be implemented. But I think it should be part of the wider funding mechanism and funding costs that are estimated. Whether they should be as part of the national payroll is another entire discussion, and I'm not sure it has a yes/no answer on that. Whether they have to be paid by the government, or they have to be paid by the district, or they have to be paid by the municipality, that's also very context dependent. So I think these are things that need to be discussed on a case by case, but clearly this is a topic of the discussion that we need to have when we are establishing a community program.
Great. And I think Abdias, you wanted to join this part of the conversation. Abdias, over to you.
Oui, merci. Oui, merci,
Yes,
Kevin. Donc,
thank you, Kevin.
pour nous, notre expérience, nous pensons que,
As to our own experience, we do believe that community health workers should be part of the health pyramid system. One example, in Niger, ASC is part of the health system. I mean, CHWs, and there was a strike.
Nous avons constaté l'impact, le rôle réel de ces ASC. Donc, si on arrive à les intégrer dans le système de santé et que l'État peut assurer
if they can be included in the healthcare system, it would be great. But
pour chaque État de s'engager, chaque ministère de la Santé de s'engager.
It's difficult for each MOH to be committed. In Mali, there was a reform of the healthcare system, and the objective was to include a community health worker within the national health system. And in Mauritania, since the community health workers were not really motivated, so we have helped them develop activities that are profitable, so that it's an incentive in a way. And that's the experience we've had when we implemented the program in Mauritania. That's what I wanted to add to the debate.
Michel, are you with us?
Oui, a permis que je revienne vers vous, que je vous entende depuis quelques minutes. Est-ce que vous m'entendez?
I can hear you.
Yes. So, Michel, I would like to ask you the question that Jerome had addressed, the dilemmas, the particular dilemmas faced by running community managed preventive and curative activities in very unstable contexts.
Oui. Justement, je suis au nord Cameroun dans cette condition-là.
I'm in the north of Cameroon today, in an unstable setting, and I agree 100% with Jérôme on the need to have community health services in unstable areas. And some 50% of the MSF Switzerland programs are held in unsecure and unstable settings. So it means that we have a further need to supervise. But in North Cameroon and in Nigeria, it's really difficult. And I will give you some examples. In many health areas where you have IDPs, the staff maybe sometimes could not stay there. So we've had to develop community healthcare But the training could be provided with the local departments and the local health authorities. But then the problem is supervision. Supervision is key, as we've heard. And in some areas, for 6 months, there was no possibility for us to supervise. So we tried to design some mechanisms to provide some kind of quality assurance, ways to support, coach, and develop further supervision. So there would be some liaison, community liaison, who would be going by foot or by bicycle to some areas to provide some training and coaching. So simulation is another tool that we can try. We can also have a role play as a training tool, but we have a great difficulty indeed in supervising in order to ensure that the quality of care is there. And in these unstable areas, we're also faced with a referral problem. The two health areas where we are cannot operate, so referral is very difficult. There are swamps in the neighboring area to go to the other health centers, so it's very difficult. And what I realized is that we need to simplify the tools and the methodologies as far as possible, because this keeping things simple makes things easier for us. And then there's a problem of supplies. Here again, we have some mechanisms. We don't want to have too much time between shipments. So we need to make some trade-offs on quality, supervision, and supply.
Thank you very much, Michel. I would like to come back to Salimata. I think she had a point she wanted to make. Salimata, are you there?
Okay, merci.
Thank you. I wanted also to say a few words about the implementation of such programs in unstable areas. It's very difficult, but it's also very important for the beneficiaries. With our research program currently underway in the north and in Gao, we have rolled out this project in an unstable region.
Et ce que nous avons fait à propos de ce projet, nous avons
project,
surtout les protocoles simplifiés en comparaison avec
the simplified protocol as opposed to the standard protocol. And our objective was to make people aware of the need to use simplified protocol in unstable settings. As was said by Michel, you need to simplify the tools. Supervision indeed is difficult. And we have to have frequent visits in the field. It's difficult. Training sessions are also difficult to organize. That's why we have developed online training sessions. So it's difficult indeed, but nevertheless, we've had some results. We had a sample of 1,700 in our current program. And we've multiplied by 3 our sample in less than a year. So it means that these there are truly needs in the communities, but because of the lack of security and because they're remote, they do not have all access to all healthcare. So we need to simplify tools so that we can implement program in unstable regions. Thank you.
Thank you very much, Salimata. I am going to come back to you, Teresa. One question I have, we've heard here various utilization of community health worker managed severe acute malnutrition, the challenges in unstable environments, family dot for pediatric TB, multi-drug resistant TB. A question I have is, how far do you think we can go? Like, how far is too far? Me personally, I think moms could probably be taught how to responsibly test and treat for malaria in the home. That's just my own perspective. I think it would require a lot of research, but as the director of operations for an MSF section, how far do you think this could go without sort of just displacing the responsibility of a broken health system onto community health workers?
I'm a little bit more open to try things and to do things, because I think we are far from the limit. But it is a matter of doing step by step. But I think we are far from the limit. We are far from the capacity of each member of the community to do more, and I think we still have a path to do. But I also think we have to invest in how this is applicable to, I mean, how we make it easy to happen and not to take risk. And there are a lot of small initiatives that I think they are super interesting, that they are giving us more possibilities, and it is when we go low tech, you know, where we go very based on making something easy to use by the people, no? And I'm only to say, I think we have still more things that we will be able to do. We have to go step by step, and we have to try in a safe way. But I'm quite sure that in 5 years' time we will be discussing about more things than today.
Michel, I see you wanted to jump in and answer this question as well. So the floor is yours.
Oui, je peux partager notre expérience.
Yes, I could share our experience, because indeed it's pretty dependent on the settings where you are. We've been very careful in the district where we are. There are so many cases of malaria and malnutrition that we said we would only tackle and target the under 5 with malaria and diarrhea, and then we would scale up with malnutrition. We have 300 community liaisons. In Peru, in Ituri, we started with the usual package. 1 year later, we added family planning, and it was successful. And we also added moderate malnutrition. So it all depends on the supervision capacity, but also what the community liaison can do. In Congo, sometimes they had up to 25 patients a day, which was far too many. So the village built up a larger wood house, and we've added 4 to 5 community liaisons. We adapt the staff of community liaisons as a function of the local population, so that there can be some turnover. And that's an example. And in Burkina, we also have very interesting initiatives in some health districts with some MCDs who've asked us to support them. We're targeting smaller communities, and we have 3 diseases that were included in the package, and we've added malnutrition. And we were also asked to add some work with the traditional birth givers, that is, mothers have great difficulties to go to the health center for the delivery of their babies. So we wanted to find some ways to provide home support and local neonatal care at home. So we've designed various solutions. Now, what is the limit? How far can we go? Well, it all depends on the settings and how much support you can provide. And I agree with Jérôme. If we ask more work from the community health workers, there should be more incentives and the wages should be proportional to the workload. We're working on several avenues we're thinking of depending on the settings, but then the tools have to be very simple, because if you have malnutrition plus malaria plus diarrhea plus this plus that, tools will be far too complex. So we need to have something, a set of tools that are realistic, pragmatic, and simple.
Thank you very much, Michel. We have a question from the audience here. And this is right, we've been focusing quite a bit on pediatric care. So the question is, where does neonatal and maternity care come into this? Can any of the panelists share experiences of community-based antenatal, postnatal care in humanitarian crises? And I can direct that to Teresa, Michel, Abdia, or Jérôme, and whoever gets to their microphone first and give the first answer.
Yeah, I'm happy to start. I mean, I can see that everybody's silent, so I'm going to jump in. I think the question is related to the same thing we just said, and Michel highlighted as well, is the challenge of adding more and more interventions into the portfolio or to the package of care delivered by the community health workers. This being said, my experience is that and it's also going back to what Teresa said. I mean, we are underestimating. My experience in the field is that we are underestimating the capacity of families and community members to deliver relatively complex and sophisticated services, and actually they can do much more than what we task them to do, but they can do it if they are appropriately supervised, trained, equipped, and as part of a system. So we go back to the same initial question: is how do we? It's not whether they can do it or does that affect the volume of work is too important. Is how are we capable as organization, as system, as to empower them and to support them in delivering these services. So on the specific to neonatal, I am on antenatal care, and I'm not very good, and I don't have a lot of experience. On neonatal care, there was some. There is a guidance that was developed by WHO on case management of possible serious bacterial infection for infants and newborn. In 2015, I've initially started to see how the implementation of this. It's been tested in Ethiopia and in Nigeria. There are some publication on this. I can share the reference. My experience is that it's possible, but as always, the more you add, the more it is complex to have a system that is strong enough to support the frontline workers. It's possible. I think it's possible, but the level of investment that is required to support the frontline workers is more and more important. So we need to prioritize based on the epidemiology. But if this is the main epidemiological concerns or the main problem of the communities, clearly it's an investment that should be made.
Yes, I think that is an excellent point. And Michel, I would like to give the microphone to you, and this will be the last word before we go to a wrap-up.
Oui, en complément sur ce point
As a
clé.
complement to this key point on neonatal and maternal care, between the MSF sections and the pediatric and Mothers of health of mothers, a reference. We have been working on that, but we still haven't come to a final decision. For neonatal care, for instance, our mortality surveys show that neonatal mortality rates are very high in the various refugee camps where we work. So altogether, we would need to work on that. So we're thinking about having a simplified package and then an intermediate level, and then a more sophisticated guide for neonatal care, depending on the sendings, depending on the capacity to train and supervise, and depending on the capacity or the skills levels observed, because in some unstable areas, in remote, unstable areas, we cannot be too sophisticated. We could have some tools developed in the local languages, but we need to have some people with the skills to implement that. And then we have to implement and leverage on this. But I think that in Burkina, our partner says that it's impossible to go to some villages and that something has to be done. So we are trying to develop something as simple as possible to develop that. We're thinking about hygiene, umbilical cord, the kangaroo method, to train local community health workers and women. It's a whole program, but it's not easy to implement because we need to truly to simplify and have all the tools to train and supervise. It's a real challenge, and it's a very important question.
Thank you very much, Michel. I would like to give Abdias one last word for a quick message of maybe what we should remember from this session. And I will ask Teresa that after, but Abdias, to you. What should we remember from this session as a key takeaway?
Merci, Kevin.
Thank you very much, Kevin. In my view, the take-home message from this session is that the CWH really make the difference. They are an added value to boost health coverage, whether it is for SAM or for other diseases such as malaria, or also pneumonia. So I'd say that there are still some challenges for care. However, with the commitment from all partners, I do think that it's possible to integrate the CWH in the system, making sure that community is at the very heart of our action.
From your vantage point, is there one key message that people should take away from this session?
I would say that all of us in MSF, we are trying to improve our people-centeredness approach, and this is to bring the communities to create a continuum of care, to be as close to the communities and their needs. And for this, the community-based work is a must. So I think we have to continue to invest. We have to challenge ourselves and to listen to the communities and to see what they can offer and what we can offer.
Thank you very much. So we're coming to the end of this session, and I wanted to give a couple of points of recap of what we've been talking about today. Community models of care, first and foremost, should be built upon existing capacity in communities and strengthen the role of the community as an essential part of the health system. There are many challenges, several that are faced in relatively stable settings, but particularly in unstable settings. And I think the key points of supervision and training and equipping people with the right tools, with simple tools, is a huge point. I think something Jerome said about prioritizing based on epidemiological need or the epidemiological profile of the setting is also incredibly key. And I think most people were in agreement that we are far from the limits of what can be accomplished, but we do not want to overburden any community health members or displace blame to families for broken health systems. And then the question of remuneration. For me, I think we did talk about it, but for me, this is a sort of a red line. We need to demand financing mechanisms, demand international donors to prioritize this as a key part of making sure that community health community health needs are met. And then finally, as we heard from the mothers in the videos at the beginning, they were animated, and one mother who said, now we can receive care closer to home. I think that, for me, says it all. So thank you very much for joining us today, and I wish you all the rest of a beautiful conference.